Now, we're very, very fortunate that we're going last, which is not what I expected, and only because so much groundwork has been laid discussing the effects of loneliness, of minority stress, of community involvement and support networks, and how Sex Now was, what Sex Now is, and how analysis from that is helpful. And so please keep those things in mind during our presentation, because they'll allow me to move quite quickly through my part and get to the more interesting parts, which are Kiarmin's. Before I begin, I'll say that from where we work, is a nonprofit, a peer-based nonprofit society dedicated to strengthening the health and well-being of gay, bi, trans, two-spirit, and queer men. We offer custom-tailored options for sexual health testing, I came up with that, including vaccination, treatment, and prevention options. We also offer counseling, sexual health education, and a variety of social and volunteer opportunities. We take an integrated approach to gay men's health, focusing on determinants of overall health, including the physical, social, sexual, and mental. So the work that we'll be presenting here today sort of lives in that umbrella of the work that HIM does. So to start, while we're discussing outness to mean disclosure of our sexual and romantic selves, for some of us being out can mean a number of different things. It means maybe our experiences with sex work or HIV status, our housing situation, or trans experiences. Queer people face a number of health and social disparities that we have to decide how to navigate every day, and I think we've done a really good job here of acknowledging that. So how this presentation is going to work is I'm going to tell you very quickly about the population that we're working with, the unique health inequities that, they face based on published research, as well as some information that came out of Sex Now. Kiarmin is going to tell you what we learned from specific consultations we conducted with community members about how those barriers to access express themselves in a local context. And then we're going to share how HIM and partner organizations are moving forward to address these needs that we'll tell you all about. And maybe I'll just take a second to say that this intervention was really born out of my experiences as an immigrant, Mexican, Jewish, Arab, gay man, societies that are very family-oriented and where being out or coming out is maybe more complicated than you might think. Okay. All right. In Sex Now 2014-15, in a binary question, 27.2% of participants said they had never come out about their sexuality. In more urban areas like Vancouver, that number looks a little bit lower, but in surrounding suburban areas like we have here in the Fraser Region, the number comes closer to the national average. I will say that the literature, the published literature, suggests that these numbers are probably quite low because guys who are, or GBT2Q who are less out are probably less likely to do a survey like Sex Now. Furthermore, when offered a scale from no one knows to everyone knows in different groups of people in their lives, their friends, their families, their communities, the numbers become more complicated, giving us our first glimpse that while we often think of outness as a binary out, not out, GBT2Q's experiences with outness are situational and context dependent. Again, moving quickly. When asked if they'd ever told a healthcare provider about their having sex with other men, any healthcare provider, nearly 60% of respondents in Vancouver and Fraser Region answered that they hadn't or weren't sure. Again, that's compared to about the 20% who said that they weren't out. So we see the numbers being, more fluid. So based on that information, we conducted a literature review, and I'll first talk about sort of the sexual health aspect of and realities for GBT2Q who are less out. First of all, in testing an HIV and STBBI incidence rates, self-reported STBBI and HIV incident rates are about on par as those of us who are more out, which might be surprising. But again, researchers caution us against taking these self-reported numbers at face value, again acknowledging that GBT2Q are probably less likely to participate in research studies that measure these kinds of things. Furthermore, guys who are, or GBT2Q who are less out are, there is evidence to suggest that they are less aware that they have HIV compared to those who are more out and also have HIV. When it comes to testing, little research has been done on the way some combination prevention tools are taken up by guys who are less out versus those who are more out. But when it comes to testing, it seems like there is quite a bit of evidence that GBT2Q who are less out are less likely to have ever been tested for HIV. There's also, I saw some evidence in Sex Now or some data that suggested that guys who are less out are also less likely to do testing regularly. And then this is an interesting one for me in my role as in health promotion. When it comes to health literacy, the literature suggests that GBT2Q who are less out are less sexual health literate and have maybe uninformed low risk perceptions, risk being used in quotations, for their potentially picking up HIV or STBBIs. Now, thank you, whomever spoke about syndemics. I'm not going to have to go into it too deeply, but taking a syndemics framework, we see that the literature shows that there's a significantly stronger association between syndemic conditions and sexual risk-taking associated with syndemic conditions for GBT2Q who are less out compared to GBT2Q who are more out and face similar syndemic conditions. I know it's a handful. These syndemic problems might include high-risk sexual activities, higher HIV and STBBI prevalence, higher rates of unprotected anal sex with a stranger as compared to others who cope with syndemic conditions but are more out. And an interesting and difficult subject is that there is not quite a bit of literature, but I think very convincing literature that intimate partner violence occurs more regularly in relationships, in male-male relationships where one or both partners are not out. And that might just be to do with some power dynamics, which Kiarmin is going to speak to. In Sex Now, we spoke about the importance of social networks. I saw quite a bit of data that suggested that those of us who are less out are more likely to have no one that we could turn to in a time of crisis. My understanding of how Sex Now 2014-15 tried to ask the question related to social supports and networks. That's just an interesting fact. Okay, stigma concealment. While there is established literature that shows that belonging to a stigmatized group is associated with multiple negative health effects, sexuality is interesting because it's one of those stigmas that can be theoretically concealed from a hostile society, unlike, for example, belonging to a visible minority or having a visible disability. You might be surprised to find that there are, actually you might not be surprised, people in this room, that this has some positive health outcomes, actually. You avoid homophobic stigma and discrimination, which itself can result in mental health problems, anxiety, depression, elevated rates of anxiety and depression. On the other hand, preoccupation with a stigmatized attribute is shown to impair social relationships, have an association with anxiety and decreased self-esteem, higher rates of shame, guilt, and disrupted relationships, and again, depression and anxiety, harm intimacy, social relationships, and increase negative feelings associated with that secrecy. And there is some work that shows that those of us who are less out have increased levels of minority stress, and we've already talked about what it would mean to have increased levels of minority stress. Thank you for doing that, Megan. Okay, so what's sort of the upshot here? The upshot is that GBT2Q who are less out have a number of very unique health inequities and health needs that are being unaddressed, right? Whether they're whether they're worse or or better than those of us who are more out, that's kind of besides the point. What matters here is that it's obvious that there's a need here and that maybe there's not enough being done to address them. Kiarmin.
Thank you, Simon. Hi. I will tell you a little bit more about what the community consultations and expert consultations told us. So the research showed that less out GBT2Q have unique needs that go unaddressed. We took what we learned from the literature review and we wanted to explore how it applies in a local context. And a lot of interesting themes came up, but I want to specifically talk about one before we move forward to the next slide, and that is that these guys have weaker social support networks and the inability to discuss parts of lives with their loved ones. A community member that we interviewed talked of a time in his life when he was experiencing a breakup and couldn't discuss it with his loved ones, with his family and friends. He described this unique form of concealment as an in-between space, a space where he constantly has to navigate and consequently results in feelings of extreme isolation and loneliness. And he feels he can't belong to the mainstream straight community, nor can he belong to the queer community. Okay, so we did expert and community consultations, and we did a series of interviews and focus groups. These included 5 one-on-one consultations with people in the field, 8 one-on-one key informant interviews with the target population through direct and open recruitment. We also did 2 focus groups, one with community members with various levels of outness, and another one with Vancouver Coastal Health's Stop HIV and AIDS team nurses and nurse practitioners. And the participants were asked to speak from their own experiences and point of views, and consultations were focused on interrogating the identified unique needs that we saw in the literature review, as well as exploring the language that our target population prefers to be talked in order to increase participation and decrease intimidation. Okay, language. Language has 2 parts, clinical and community. So in clinical settings, the community members reported that behavior-based language was preferred to identity-based language. They found that labels can be a deterrent from testing, and using clinical language that purely refers to behavior in absence of a suggested identity allows for self-identification and promotes testing and encourages participation. The healthcare practitioners that we consulted with recommended the use of behavior-based language that is applicable to all GBT2Q, to the guy who is more out, whatever that means, to the person who identifies as straight but goes to the bathhouse occasionally and doesn't necessarily register that as queer sex. Another option for a clinical setting, but that was suggested by a participant, was framing the question as an incidental act as opposed to an ongoing behavior. So instead of saying men who have sex with men, saying men who have had sex with a man. That again allows room for self-identification and some more discretion, which promotes testing. So this presents, of course, a challenge between having these strategies, these great strategies that we have to make spaces more welcoming to this population, but at the same time not wanting to de-queer spaces. We don't want to alienate people whose queer identities inform a lot of who they are and how they participate in our programming. So, and I mean, there's a lot been written about this, and I'm sure it's a point that's contested. It is something that we are navigating, and it is an ongoing conversation. Okay, so the next theme that came up was power dynamics. This one was interesting. It was the relationship between power and outness, especially how participants saw higher levels of comfort with outness equating to more societal power. So one of the people that we interviewed said, you look at a guy that's out, if somebody says something homophobic to him, he's more likely to defend himself. So this showed a unique characteristic about power in relationship, the relationship between power, that it is a two-way relationship. So a person's positionality and societal power allows them to be out and feel more comfortable about their stigmatized identity. And on the other hand, a person's confidence in their outness adds to the power they already hold in society. Acknowledging this shows LESAP community members that as a community organization, we understand the intersectional nature of outness. And it allows us to interrogate the concept better and empower community members to think about this relationship and how it plays out in their own lives. The next thing that came up was stigma and isolation. This was a theme that emerged that was almost unanimous in all of the interviews. The internalizing of stigma and shame, and then facing stigma from queer community resulting in isolation. So this was internalizing of a double stigma, and community members feeling judged by the queer community whilst feeling the internalized shame. It made participation in community really difficult, and it contributed to feelings of isolation and loneliness. This inability to discuss and share important parts of life, like a breakup that we mentioned in the previous slide, played with this, and then paired with the inability to connect to the community of other sexual minorities, results in a unique form of isolation among these community members. The next theme that emerged, there it is, culturally specific and nuanced understanding of outness. So this is something that both presented an opportunity and a limitation. Our understanding of outness is rooted, we know, very much in Western lens, where sexual behavior directly links to identity. But what we know is that a lot of cultures around the world and in Canada, this isn't the case, and it's less concrete, it's more fluid. For example, one of the people that we spoke to talked about his experience in the Filipino context. In his experience, coming out coming out is not so much a declarative action, but it is a performative state of being. So what that looks like, that is, it's more flexible and adaptable to different situations. In fact, coming out of the closet, from what he reported, the metaphor doesn't make sense in a Filipino context. It is more unfurling one's cape, but the understanding that you can furl it back depending on the situation. So that was interesting. So there are diverse perceptions and lenses. So this presented as an opportunity to contribute to our understanding of outness, and how we discuss and interrogate it in our programming. While exploring the concepts that we call outness, we understand that our perception is shaped by colonialism. And then this perception is internalized by many GBT2Q, including those of us who have different cultures but live in this culture right now. This is especially important, recognizing where we are on unceded land, recognizing that Indigenous people who have lived here for long before Canadian history was recorded have practiced cultures, and many of these cultures have integrated and viewed queerness and two-spirit identities in distinct ways than Western colonial framework that most of us are most familiar with. Okay, lastly, empowerment, everyone's favorite word. So we know that there are many reasons why people don't come out and keep private about their sex and romantic lives. And to reiterate, we believe it should be up to the individual to decide when and how to be out. With this understanding, we aim to provide tools and strategies to meet people where they are at, navigating the in-between space with the tools and strategies necessary to reduce stress and increase access to testing, mental health, and community. So this includes, for example, tools to navigate family relationships better if you can't come out to them. Navigating identity and sexuality may be complex, but access to healthcare, access to community and mental health doesn't have to be. So what are the next steps?
Kirk is going to humor me. What is the upshot of this? In February, Health Initiative for Men and our partner organizations are launching an intervention called OUTSIDEIN. OUTSIDEIN is a multi-pronged intervention, the first of which is a evidence-based social marketing campaign. We want to sort of interrogate outness in the community, regardless of our levels of outness, and sort of show what Kiarmin talked about, that it is fluid, situational, complicated, and intersectional. The messaging might be, you don't need to be out to access testing, take time for your mind, or find community. In a word, oh, is it not working? You don't have to be out to let him in. Malachi, our community trainee, came up with that. Activities and programs that will be accompanying this social marketing campaign include a web resource and referral hub, again, promoting these ideas that we have and referring people who are less out to services they might not even know they need. Facilitated workshops run in all of our social health groups, as well as that of some of our partner organizations, including, it seems, our friends at YouthCo. A mental health skills building group, which will build up people's coping abilities for those of us who struggle with outness. A community dialogue to sort of cap off the intervention and sort of debrief on what was learned and to identify next steps. And finally, there will be a capacity building piece wherein we take what we learned from the community consultations, the health literacy, the health literature, and try to disseminate that to appropriate service providers, both sexual and mental, in order to ensure that they're delivering their services in a way that is accessible to our community members who are less out. Okay, Kirk, I think we're done. But really, yes. Thank you to everyone who's spoken with us, and if you'd like to speak to us more about this, this project, please email or talk to us. We're happy to chat with you about it.